So, hello everybody. My name is Chantal Dumoulin. I'm from Canada. I'm funded by my university, my institution, from the Canadian Institute of Health Research, who support my research, from the Canadian Research Chairs, and from the Canadian Foundation on Innovation. I want to say that I'm a physiotherapist by profession. I still do physiotherapy 1 day a week, and I treat patients with incontinence and various pelvic floor dysfunction. And I also teach and do research the rest of the week. So where do I go from here? Okay, I just wanted to say maybe to start with that I feel like I'm a little bit of an imposter compared to those guys because I don't have the same background. I'm not doing so much research on these models, but what I'm going to bring to you today is really my experience with the women in my clinical trials, because at the end of each clinical trials, and even during those trials, we ask the women what would make them participate or adhere more to their intervention. So I'm going to be talking to you about specific population with reference to the COMBI model. Mostly, I will be talking to you about facilitators and barriers related to older population, older women, which are my population of interest. But I thought that other population that were more fragile, like migrant population and neurological population, it would be interested also to talk about. And I wrote that I'm going to be talking about stroke, MS, Parkinson, and epilepsy patient because that's on the clientele I found literature. So you know that model by now, so I think I'm going to skip that. And you know what COMBI means now, the 3 letters that Doreen has showed you, so capability, motivation, and opportunity. So let's look at these aging patients. Whoops. Okay, so when looking at the literature on older adults and with pelvic floor muscle training, there is a few papers in our abstract in the literature looking at older women with incontinence and looking at qualitative data on their barriers and facilitators to adhering to those treatments. Older adults, I found a systematic review with 2 papers looking more closely at the elderly clientele, both men and women, one in patient in institution and one in the community. And finally, I also found, and I thought this was of interest, literature on adherence to physical exercise. So we can maybe transfer some information from that. So if we look at the capability to do or to adopt pelvic floor muscle training, barriers that can confront in elderly population is often low education level or literacy level. I don't know in your country, but in Canada, a lot of elderly people don't know how to read. So you have to take that into consideration when you will make forward a little leaflet about the exercise or when you give a sheet of information to your patient. So you might think this is very basic, but if they don't understand how to do it, how can they be capable to reproduce their pelvic floor exercise program? So low level of knowledge also about the pelvic floor dysfunction. Often in our research and even in the practice, I see women with great fear because they have a prolapse. They think it's a lump, it might be a cancer. So they're very, very scared about that. And they might not go to see the physiotherapist, or they might not want to do exercise because they're afraid of what it's going to do to that lump. They might also think it's normal to have urinary incontinence or to have nocturia when you're 60 years old. And Jean was talking about the models, and maybe somebody is saying, you know, it's normal because you had 4 children. It's normal, you're 70 years old. So you have those information that maybe women think it's normal to have those problems. And how will she start to do exercise if she thinks she doesn't have a problem? There's also low level of knowledge about pelvic floor anatomy. And actually, there is taboo related to this anatomical region. In Canada, again, in my province in Quebec, those elderly people right now, they were very religious. And that part of their body, they were not so aware of what was happening there. Some of those ladies told me that they haven't even looked at that area in their life. So how can you contract your pelvic floor if you don't even know about this area? So you need to know more about this. So this is something very important. Reluctance to discuss these issues with the health professional, again, because of religion or because of their generation. This is not something we talk about. Reluctance to have a gynecological evaluation. Oh, I heard that the physiotherapists, they make you do exercise, but they have to test your muscle. And I don't want to have that test. So they don't really understand why, and maybe that's why they don't want to do it. Maybe there's a way for you to show them how to do the pelvic floor exercise before you get to the gynecological exam. There's also taboo, and we talked about it before, associated with incontinence. Incontinence is related to old age. So if you have incontinence, you think you're older. So maybe you don't want to say to another person that you have incontinence and you want to get treated. Maybe you think, well, maybe it's just that I'm getting too old. It's related to ugliness, incontinence. Jean was talking about what they're doing with the pads. So you feel ugly. So maybe you don't want to get treatment. You feel dirty, so you don't want to talk about that. So these are barriers that might make those elderly patients not come forward to you. Now, these are examples of facilitator that I found in the literature, that I found with my ladies in my randomized trials, but I'm sure, like Sarah was saying before, that you have plenty more in your practice. So what we do is we use simple written information. We use large font. We even got to talk with the optometrist and try to find the best font for older people. Because some of the ladies told us, oh, we don't like those italic words. We're not so sure what they mean. So they really like to have different kinds of font. Use simple drawings for anatomy. We're used to have very fancy drawings, but maybe those older people, they want to see the basics at the beginning. Inform your patient about anatomy, and you know, it goes back to even definition. What is the bladder? What is the urethra? You're talking maybe about the detrusor. You're talking about the pelvic floor muscle. Where are those structures? What are those structures? Prevalence of pelvic floor muscle dysfunction. Effectiveness. We were talking about that before. Effectiveness of those interventions. If they're going to be doing those interventions, there are evidence. Jean was talking about the Cochrane review. We know there are evidence, even in the older population, that it's effective to treat incontinence. I missed one. Prevalence. Yeah, about prevalence. I think it's really important to tell those women about the prevalence, that they're not alone, that there are so many other women that have the same problem. Use various teaching methods other than internal digital palpation. I don't know if you probably know many of them. I teach group pelvic floor muscle training in our randomized trial. We have all the women lying down, putting their hands on the perineum and trying to feel it. And this could be a start for them to have a contact with that area. Eventually, if they don't understand how to do it, you can go one-on-one with the digital evaluation. But that could be a first step toward there. invite discussion among the participant. We have class, and again, we invite different discussion and invite them to ask question. I ask question to the participant, and I tell them, okay, I'm asking you a question, you have all the documentation, and then next week we will discuss that question together. So that's another way of teaching, not only going with facts, but making them participate to your session. Breaking the taboos, using group training. And I think I'm an advocate for group training because I do many projects with group training, but really I encourage you to go see my student, short oral presentation number 500. She will show you how group training appears to break taboo. At least that's what the older ladies tells us. And about that ugliness that Jean was talking about and that dirtiness, we have had some women in our exercise class telling us, I came to the exercise class the first day and I saw that lady sitting beside me. She was not ugly, she was not dirty, and I thought, she has incontinence like me. So I'm not that bad, I can do it. So that helped her to adhere and to participate to that class. So I encourage you to go there. So these are examples. See those letters? This is the not to do. They didn't like it. The exercise program with the letters, a little bit fancy letters, they didn't like that. So it's just to show you, we have in our program large drawing. We try to, after that, use other type of font so that the women would have less difficulty understanding our program. Here you can see session 1. Every session, we give a little bit of information. And you do that in each of your sessions. You talk to your patient and you give them a little bit of information about the pelvic floor or about the exercise, about the anatomy. We decided to have small part in every session of our treatment. We decided to have information on a paper. Women could bring that home and we had those questions. So they had to maybe go back home, read it one more time, and question themselves. This question was, is urinary incontinence a normal part of aging process? And then we would discuss that on the next session. So with the reading that they had, they could go on and understand better and maybe, have an idea about the answer around that. And we would discuss that in the next session, because this was an important point. We wanted them to know that it was not normal and there were some things that they could do. So we wanted to reinforce that. And those things that we want to reinforce, we put them into question. So that's another way to make it maybe put more pressure on those things. Opportunity to adopt pelvic floor muscle training. Barriers regarding opportunity, sometimes it's just a schedule. We realize that older participants to research or even to treatment, they prefer the day intervention. Not too early because there's traffic, not too late because they don't want to be in the dark. There's church time also for some of them. There's siesta time for my Brazilian and my Venezuelan participant. And also there is weather problems. So in Canada, in January, it's never a good idea to start a session. So you try to start session more in March and you have better chance for it to work. Barriers to adopt pelvic floor muscle training, the fact that they can miss some of the training session. So if you say either in a study or in a treatment, we need about 3 months. That's what the literature tells us, that we need 3 months to train that pelvic floor muscle. But along those 3 months, you will need to come maybe 12 times, but if you have something, as long as you come 8 or 10 out of those 12 times, because older people, they have medical appointments sometimes, their partner has appointments, there can be illness in the family, there can be funerals they have to go to. There can be family issues. I have to babysit my granddaughters. Those are real issues why they will not come. So, and sometimes they are traveling. Say, oh, I will come, but I have to travel. Yes, we can work around that. So as long as within your contract, you make sure that you put that in, that could be a facilitator for them. The distance from home, it's nice to try to have a central point to give your service. If it's not possible, it's really important to be able to give them information about either car, metro, bus, or routes, if possible, free parking. What we did also for older ladies is that we organize with a charity organization to have helpers who would drive our older people to the research. So there are those organizations that want to help older people, and they were providing a service of taxi to those ladies. So these things exist in the community. I think it's important for you to try to find them out. There is also financial constraint, and I saw before today that there was a problem with that. And I'm saying maybe group training might be less costly than individual training. I agree that it's not for everyone, but at least for some patients it can be interesting. So this is not in the same sheet, but this is example of what we're giving to those women. Now, last part for the older women, motivation to adopt pelvic floor muscle training, the barriers and the facilitators. Well, the barriers might be that, do they really desire to reduce their pelvic floor muscle symptoms? Do they really know that it's abnormal? So if they really desire, they will be able to do it. So how can you facilitate that? Severity of the symptoms, that comes also out in the literature. If for them it's normal to have some leakage from time to time, this is not severe. If you tell them that they can improve from that, then it can increase their motivation. The impact on their quality of life. Are they missing any activities? Comorbidity and polymedication is a big barrier for them. If they have other problems, maybe their pelvic floor muscle training is not their priority right now. So maybe it's time to deal with these things and then come back to the pelvic floor muscle training. Sometimes they want to avoid medication or surgery, so that's a big motivator to do pelvic floor muscle training. And also cost of pads and hygienic product could be a motivator. Following doctor's recommendation. A lot of the women that I've seen in the research and clinical practice, they say, if my doctor tells me it's a good thing, I will do it. So you need to go and talk to those doctors, and you also need to make your recommendation. You know, you're the expert, we were saying before, in these interventions, the nurse and the physios. We are the expert. We have the evidence behind us. So we need to show that we have that expertise and that we can help. Peer and family support will help in motivation. We have talked about that. Doreen has talked about that. What we decided to do was mother and daughter information session, 3 minutes. So I think that's a good way if you're giving those sessions, lecture, you can invite the daughter, and at the same time, the daughter will be informed, and she might be more inclined to help the mother and not give so much babysitting to the mother so that the mother can do her exercise. So we thought it was working well, and they were helping each other. enjoyment associated with engagement in the activity. It has to be fun. So you need to use music or to use different games for them to come back. Elderly people, they don't just want to do things, they want to have fun, they want it to be social. And be careful with ageism, because those people think that because they're too old, there's nothing to do. So you really have to put forward the fact that even if they're older, there is a possibility. So this is an example of the exercise class that we do, and we play the games, the Dance Dance Revolution game, in that we contract the pelvic floor while we dance to different music. So I only have 2 minutes maybe. So I'm just going to go with immigrants because I think it's interesting and it's really not long. We saw when we worked before that we might have had sometimes some language difficulty in interpreting the words and trying to find the connection in the activity that we did before. With immigrant, it can be a big problem, language barrier, literacy issue also, and shame and taboo related to the religion or to the culture. So in the literature, what it says is to involve a health leader within the community, to try to involve somebody from that community in developing and implementing your program. So that it's not only a program that you have done, but it's a program that resembles more those people. Provide cultural specific exercise. For example, squatting in, I was having ladies that were from Asia, and they were telling me that they were often in the squatting position. So this was something that we integrated in the exercise program. Recruit an instructor who speaks the language, if possible, who communicate well with these immigrants, and also who hold similar value. I think it's really important too. Facilitator offer individual or group instruction and intervention, because if you have a few new immigrant that comes to your class, they might have difficulty following, so you might want to offer them some individual instruction. Involve champion, somebody who have had a good success with the program, a peer of those patients. Involve that peer into maybe coming with you when you do a presentation in the community, and weave component of the culture such as either music, exercise, or dance into the program. So opportunity, often knowledge of the people, the immigrant, don't know about the availability of those programs, so you have to work on that. Access to the program, transportation, again, maybe within the community, you can have help from people to give transportation, and there's often an issue about insurance and money. So you partner with the community, the social service, you share information about the local program within the community. You can maybe link it with an activity of this community center. And you try to offer, again, low cost or no cost class. So I think I'm gonna stop here, Elena. So I also add for neurological patients, but again, I think what's important is to say that these patients have specific issue. However, like Doreen was saying, everybody's individual. It's not because you're an immigrant, you're an older person, or you're a neurological patient that you have exactly what I said. These are more frequent. These facilitator and barriers are more frequent. But this is to take into account. So thank you for your attention.